Hello, everybody, and welcome to another episode of the Sensory Approach to Manual Therapy podcast. I'm Troy Levine, and today's guest is Paul Ingram, who many of you may know from painscience.com. He's a former massage therapist and a writer and author, specifically on the painscience.com, which is where he spends most of his time. And welcome, Paul. I'm glad to have you here today.
Thank you. Nice to be here.
Now, I don't think I've spoken to you several times on the phone and on Messenger, and we've texted each other quite often in the past, especially when I have questions about some of the classes I create. But this is actually the first time we meet face-to-face virtually, and I'm excited about that. I don't think I've ever told you how I got interested in your material, and I wanted to actually start the podcast with that.
No, I don't remember that. How did you get interested?
Yeah, so in 2012, I remember reading your posts on MFR and trigger points.
Yeah.
And that was like, the bread and butter of my practice. That was 99% of my practice, easily 99% of my practice. And I remember after reading them being less upset with you, which I know is a common occurrence.
Standard, really.
But more upset with the profession and frustrated because I remember having this crisis of faith moment. And for my listeners who've listened to the podcast I did with Michael Ham, it's actually titled The Crisis of Faith because it was something that I remember having. And it was like, what have I been lying to my clients about? What have I been saying? And from that moment on, it really led me down the idea of, okay, let's study neuroscience. Let's see what touch does to the brain. Let's see how interaction, what it does to the brain. Let's see what context does to the brain. Let's see how we can help our clients that have nothing to do with our hands, because that's just one component of our, what I call the theater of intervention or the theater of therapy. And so I just want to say thank you because it really opened up my eyes. And I imagine it's the same thing for a lot of people. And even though you probably do get, like you said, standard frustration, possibly even trolls or hate mail, I'm sure there's also a large population of people who hear your stuff for the first time and it sits in and it helps lead them on a journey of more exploration into what they're doing and where this profession can move forward. So I just want to say thanks to start, because that's great.
You're welcome. Thank you. Thank you for joining the team.
And then it leads me to wonder, what made you do it? What made you have that crisis of faith? Was there a specific paper? Was it just one day you woke up and it was like, oh my God, I just can't believe we've been doing this. What was the epiphany moment for you that made these changes?
Criticizing overt quackery provoked such strong reactions, was so triggering for some people that I began to get curious about why. I started asking questions about everything precisely because I was being told to stop. They told me to stop criticizing, and so I just kept going and kept asking questions and kept looking at the subject matter from fresh angles, looking for the problems. So the attempt to silence me had exactly the opposite of the intended effect.
Okay. Well, that's pretty great. Now, you were a massage therapist, and I know one of the biggest things that I know I get this question, and I'm not near as, I would say, informed, outspoken, or possibly even concrete in my thoughts. But I know I also still get people saying, well, how do you still do massage then if you're talking about it this way? How do you still, talk?
Yeah.
How do you still have a clinic and stuff like that?
Yep.
And I know you don't, but
I could.
You could, exactly. What is it that makes you still go, okay, we have this big body of evidence that shows that what manual therapy is not what we thought it was. It doesn't detoxify. It doesn't do X, Y, Z. Our mechanical forces are not significant enough to do whatever result are. Especially a lot of the stuff that's still being taught, not only in baseline education, but especially even in continuing education. And yet, you even talk about it in one of your posts, you still like massage.
Yeah.
So
I still buy massage and I would still happily supply massage if it worked for me professionally to do so.
So where in your brain, I mean, these two opposing forces, which at least they seem to be opposing forces.
Yeah, it's an illusion.
How do you reconcile them? how do you bring them together in a place where therapists who are sitting there and riling against what you said, you get to say, hey, look, no, just because this is true doesn't mean massage therapy isn't true as well.
Yeah. Mm-hmm. Yeah. Massage it feels fantastic. It's inherently pleasurable and relaxing. And there are good reasons for that don't have to have anything to do with the traditional explanations for why manual therapy works. We were just focused on the wrong thing. I was in my career. And actually, let me qualify that a little bit, because I am weirdly on the fence about trigger points. And my career was entirely based on doing trigger point therapy for 10 years. But I don't entirely regret entirely basing my career on trigger points. I think there is value in trigger point therapy as an experimental treatment, properly framed, humbly, with informed consent, with avoidance of the greatest risks, including the risk of wasting money. Properly framed, I've got no problem with doing trigger point therapy. But most of the value that I think I delivered to clients was coming from the therapeutic interaction, from the time that I spent with people, the curiosity that I showed, the compassion that I demonstrated, the pleasant sensory experience above all. We know that, in fact, the only truly evidence-based benefit of massage therapy, the only thing that we can say with confidence, we can point to and say, yes, that is definitely, essentially a proven benefit, is the reduction of anxiety and depression. And
That's not a small thing.
It's not. No, it's huge.
I mean,
think about how hard it is to treat anxiety and depression by any other means. I mean, having any impact on it all is fantastic.
And if you look at like pharmacologically, the impact financially of anxiety and medication. And I mean, I know in some countries, like when I used to live in the US, if somebody said, oh, I was getting burnt out, it was like, well, tough luck, go to work anyways. Now here in Quebec, we say épuisement in French and we say burnout, and people get burnt out, and it's accepted that your organization is going to allow you to take time. It starts with a minimum of 3 weeks and it can go much further than that, but it's become part of the culture to say, hey, we understand that's part of it. And you think anxiety, depression, mental health issues, like that is impactful to say the least. So if it can't do anything else and it only does that, that's already an incredible imprint.
Yes, even if that was literally the only benefit, it would still be arguably superior to talk therapy.
Well, and then it leads to the next question. So let's say we know that it doesn't treat anxiety. It helps reduce anxiety. And so let's say we're now reducing anxiety. And then you go, well, what's your anxiety about? Well, you can have anxiety about family, finance as well. But one of the big ones, which I know you talk tons about and possibly talk to the point of fatigue, but also probably till the point of interest, anxiety around pain.
Yeah.
Right. So like if you can reduce anxiety, I guess the next question is, does that help pain?
Mm-hmm.
And it's an interesting question, because the research would say yes and no. Some people are in the allostatic load camp, which I fall into, which is going to be the culmination of your lifetime, and the perception and the brain's interpretation of it can enhance your pain experience. And then there's others who say, no, pain is a separate experience. It can't be this conditioned thing. It can't be this thing that is enhanced through mental. The nail boot guy is a good example of that, right? So there are these theories around it. And yet, if we know anxiety is reduced, it may not reduce your pain. It may reduce the suffering, which is pain adjacent, but not technically pain. So if it can reduce anxiety and depression, where does that bring us when it comes to the mechanistic nature? Because now anxiety, depression, these are not going to be mechanistic. They're going to be outcomes. And yet pain tries to be explained mechanistically. So, and most massage therapy, especially when we're in school, is taught, even all manual therapies, as mechanistic. You put your hands on someone, you apply force here with this amount of pressure, you move in that direction, strain, counter strain, inhibition, all that kind of stuff. If anxiety, which are these conceptual things and mental state things, have an effect, what is the effect then of massage therapy or manual therapy on the mechanistic nature of the body?
Mhm. Via the reduction of anxiety. Is that
Be
what
it
you're asking?
via the reduction in anxiety, which is a good starting point, because then it's a conversation which is theoretical or philosophical in nature. It's not going to be proven. It's going to be, well, maybe these are the outcomes. And then the other part of that question would be, no, the actual impact of your hands on the body, which is a harder one for us, I think, to answer of what it does, easy to answer what it doesn't do.
Hmm. Yeah. I mean, I still hold some hope with regards to trigger point therapy, that there is an effect there. Uh, and the reason we haven't got the evidence is not necessarily because of the absence of an effect, but simply an absence of the evidence. That's fairly common in alternative medicine. We often don't have enough of the right kind of research to answer a question properly, which allows quacks to keep making claims, but also allows legitimate hope to be sustained up to a point. So I hold out some hope. I have some optimism remaining for some of the possible effects of actually putting your hands on someone's tissues, uh, but not a lot. I mostly assume that the experience of massage and what's good about it is about having a fascinating sensory experience. Uh, that, that all of the mechanisms are neurological. Um, Whether reduction in anxiety reduces pain, and we can dive in, we can and probably will dive into more detail on any of these points. I'm trying to sort of get some highlights in here. The it seems very clear to me that we don't have the evidence to say what the effect of anxiety on pain is. I think it's extremely clear that anxiety can go down and pain can go on. Anxiety can leave and pain can stay. I've seen it. I've experienced it. There's definitely nothing magic about reducing anxiety. It doesn't suddenly make pain go away, but that doesn't mean there's no effect. And it doesn't mean there can't be a profound effect in some cases. But we're definitely lacking the evidence, and evidence of absence is piling up. There are more and more clues in the evidence that simply reducing the perception of threat or anxiety or fear avoidance doesn't do it. And in some ways, even some of the big wins, for instance, the Restore trial of cognitive functional therapy, widely regarded as good news, as a good news study, it showed, substantial increases in function, uh, but not pain. People got a lot more confident, but they didn't get a lot less hurty. And there's a fair bit of evidence like that piling up now as well.
So let me ask you about that, because I find that to be one of the more unique points, because a lot of times manual therapists, they'll, I feel inappropriately tout their treatment as the reason somebody gets better. And oftentimes I feel, and I think I've read it once on your blog, manual therapy might give a temporary alleviation of symptoms, which gives them confidence to go be active. I theorize, my theory would be, okay, massage therapy or manual therapy in general gives them confidence to move, and the movement helps them improve. The movement is likely the thing that's going to cause reduction in pain, reduction in inflammation, change of fluid dynamics throughout the system, change of stress on the tissue, allowing for healing to take place, especially if they move within limits of discomfort and things like this. But that's not massage therapy helping. That's massage therapy easing to give them confidence. Now, it seems almost like a lot of people say, oh, it's a moot point. I don't think it's a moot point. It means movement is the thing that helps them. A healthy lifestyle is the thing that helps them the most. You're just giving them a window into that. You're opening a door for them to do that, as opposed to, oh, what you're doing is the cure or the treatment method. So do you find that the research around movement therapy, exercise, walking, being active, or even rehabilitative in nature seems to have similar black sheep as manual therapy? oh, the pain research doesn't show that movement helps, or the pain research, the research shows that movement does help XYZ.
Yeah, it's a real mixed bag. It's real good news, bad news. I mean, basically what we're getting to there is, does increased activity and exercise treat pain? And the general answer is no. There are lots of kinds of pain that just aren't gonna budge because you get more active. But like manual therapy itself, there do seem to be some benefits for some kinds of pain. And we know that when people get more active and more fit, they do better with osteoarthritis, for instance. And we essentially see exactly the same pattern with manual therapy and exercise therapy. Kind of, good news, bad news. There are results, but they're also kind of underwhelming. And so you'll see posts from experts and influencers pushing both ways and saying, "Great news, everybody! Exercise helps." And then the next day you'll see, "Hey, exercise doesn't really do anything." Not really. And so we have the same dilemma. What do we make of this?
Yeah, I think one of the only differences is that, let's say movement doesn't help with pain. Being more active seems to have other health benefits: cardiovascular, fat loss, adipose tissue, increase in VO2, increase in oxygen, increase in dopamine from being outside, maybe a connection to nature. There are all these that you may not get with manual therapy. And so even if the results of exercise therapy are still, good, bad, all the secondary effects seem to be really good for you, like decrease in dementia, increase in bone density, all these things like that. So that it seems to be like the good category might outweigh the secondary effects than the bad category.
Yeah. And it's a long game. This is, with manual therapy, we're talking very much about, are you better within days, weeks, months at the longest? But with exercise therapy, we might want to look at a completely different window. And most of the research focuses on, short to medium term effects of exercise. And even the longest term studies have, more or less maxed out at a year or two. But the reality is it may take much longer. It is perfectly plausible that a serious long-term 5-year plan to increase fitness could lead to substantially reduced pain with a wide variety of conditions. That's possible. No one's ever tested that. That study hasn't been done, and it may never be done.
Yeah, it would be costly and effective, and a lot of variables, and hard to isolate, and almost imaginable to think of an institution that'd be willing to put money towards that. But it's an interesting point, because I do a lot of personal training programs for my clients as well. They're in pain, they stop moving, they stop being active, and now they have a reduction in symptoms, and suddenly they want to start being active again, and they go do something, and they do it like most therapists see across the world. They do it like when they were not injured. And they think, oh, I was lifting 80 pounds, I'm going to go lift 80 pounds. And then they get re-injured. Right. And so we do programs that are specific to get back to weight training where you can be active again with lower risk of injury. Right. And I tell them, don't think in terms of weeks or months. Think in terms of the change is so gradual that within 1 year, 12 months to 18 months, you'll sit there and you go, wow, I really feel different, but when did it happen? And it's so subtle that in theory, by the end, you have the result, but you can't point back to a day and go, oh, that's the day my life changed. Absolutely. I just suddenly started feeling better over time. And that's that long-term gain with exercise.
And it's not just long-term, it also, and I'll swear to really emphasize this, it's really fucking difficult. Yeah. It can't be overstated that this is something that many people will never achieve. Significant weight loss, significant increases in muscle strength, significant increases in fitness. These are very hard jobs. Those are really difficult goals, and many people will fail at them, or their progress will be so slow and so erratic over 10 years.
They're demoralized.
They're demoralized at multiple points and remoralized at other points. And it will, and the point here is it will be completely unclear 10 years down the road when they're finally doing better, whether or not the fitness was the thing.
Yeah,
Like,
chances are they'll associate it to the last thing they did. The last 3 months.
quite likely.
Yeah,
Yeah.
the last 3 months of my life is the reason I got better,
Yeah.
not the last 10 years of my life leading up to those last 3 months. Yeah.
Yeah.
And you said it right there. It's a tough job because, like I worked with a lot of high end athletes. Well, that's their job. They take care of their body for a living.
Yeah.
And they're still not pain free. Let's
Yes, let's be clear, just because they're fit, which is another basic argument, isn't it? Just
they
being
are
fit
not
doesn't do
pain
the job.
free.
They're
Exactly.
really not.
But for everyone else who has a full-time job and a family, suddenly, oh man, or like maybe they can't afford a gym, but they also can't afford free weights, so suddenly it's more than a job. It's inaccessible almost.
Yeah. There's a very strong, in this economy, factor for increasing fitness, which is why Ozempic matters. This is why the semaglutide counts, because it helps people achieve that metabolic upgrade that is, for all intents and purposes, it's impossible for a lot of people. Let's not say impossible. Let's say inaccessible
or
extremely difficult.
Yeah, exactly.
Mm-hmm. So difficult that in practice, 90% of people will fail.
Unattainable.
Mm-hmm. Yeah.
So when you speak about the exercise stuff and you think about the long-term gain, right? Let's see, 1, 2, 3, 4, 5 years out.
Yeah.
One of the consistent theories, I don't know if you're familiar with the book, How Emotions Are Made from Lisa Barrett Feldman. She talks a lot about the prediction theory behind the brain and things like this. But one of the things that is talked about in that book a little bit is the resilience of the brain. And it's one of the common things that is more hypothesized than exercise theory, which is you're enhancing resilience. And as your resilience increases, in theory, be it pain threshold changes because perhaps you're more resilient to it. It's one of those leaps in logic kind of thing. It's not a direct this, therefore that. It's a leap in logic. But even if it wasn't just related to pain, let's say it's related to mental state, let's say it's related to energy balance, let's say it's related to motivation throughout the day, that long-term gain, is it possible that resilience is the thing that might be changing the most, the habit-forming behavior of consistently pushing your boundaries, consistently pushing your limit to get up and be active, to eat healthy, to change your lifestyle over time? And that experience is what's allowing the brain to say, okay, focus so much on this resilience or this resistance or this effort that is it just being distracted away from the other experiences of discomfort? It's more a philosophical question. It's definitely not a study or anything. It's more, is that possibly something that's happening in the brain? Because a lot of my theories are just theories and they're theories only. And I wonder if resilience might be the result behind exercise change.
Yeah, I mean, it's possible. It's plausible. I've got no problem with the idea out of the box, but I also immediately see some problems with it. Having a toe in the world of chronic illness, I'm well aware of how many people are extraordinarily disciplined and yet nevertheless struck down. And the world of chronic illness is full of stories of people who were highly resilient, highly motivated, very functional people without really the slightest indication that they might be susceptible to illness as a character flaw.
A character flaw. Is that the right word?
Well, I mean, it sounds ridiculous when I put it that way, but that's sort of deliberate. But that's exactly how it does get framed. Chronic illness patients without obvious explanation for their illness or pain are, in fact, diagnosed as having a character flaw. Effectively, they are treated like that. And so, to circle back to your question, it's pretty clear to me that people can be highly resilient and yet continue to have pain, just like they can get a lot of great manual therapy, just like they can do a lot of fitness. Resilience is manifestly evident in lots of patients with ongoing serious health issues. But that doesn't mean it's impossible that it is the mechanism by which fitness does good over time. It could be very hard to study, though, I imagine.
And I think you're getting to a point that I've often wondered, and I'd love your insight on this. When we're talking about chronic pain, so let's
Yeah.
say somebody has like, so I had my ACL redone in 2007, and I had both my meniscus root. I still run. I ran a half marathon this summer. I'm bone on bone, and I had a flare up in the fall, and I've had knee pain for 20 years.
Mm.
Technically, what you would call chronic pain.
Sure.
But I've also gone through extended periods of time ever since I started, especially specifically weightlifting and working out, where I have no pain whatsoever. And I think possibly, I'm wondering if pain science in general is missing enough. Yeah, I know we have nociceptive, neurogenic, and neuroplastic, and all these other, and acute and subacute and chronic and rehabilitative, all these terms for pain, which is definitely overwhelming and also under, I think, still not enough at the same time. My question would be, when you talk about people with chronic, when you talk about people with chronic pain, like you talk about with illness and stuff,
Yeah.
like someone with chronic, non-specific chronic low back pain, right? If they find relief, let's say from resilience, let's say from exercise, let's say from manual therapy, some version of intervention, and then somebody else has, let's say, Crohn's or fibromyalgia, you name the reason for their chronic pain. Insert X name, right?
Okay.
One gets better and one doesn't. And let's say there's two large pools of data. Some over here get better, some over here don't get better. Is it possible that pain, even though it's an evolutionary role, is it possible that it's behaving differently in these individuals versus these individuals, even though in theory, the human behaves pretty similarly across the board when we look at the big scale of evolution? You know, red blood cells tend to do the same thing. White blood cells tend to do the same things. We have abnormalities, but most of them tend to do the same thing. Is it possible that chronic pain sufferers aren't finding improvement? Is it possible that we haven't fully understood the mechanism of their pain yet, and that it needs a new category for it compared to
Yeah.
those who are finding improvement?
Yeah. Okay. Sort of two questions in one. Of course. Yeah. Of course, it's possible. And whether or not it lines up with people who seem to get better and people who don't, I'm going to go with probably not for that one, because there are too many variables. And and I think biology is destiny, and there are lots of hidden biological and pathological variables that determine whether or not we get sick and whether or not we get better, most of which are unmodifiable, out of our control, and more to my point, out of our awareness. We have no idea why it comes and goes in most cases, I suspect. And you spoke of your pain coming and going over the years. Sometimes you have fairly long periods of remission. I think you are associating those with periods when you were more active at the gym.
Yeah, usually they're more related to my leg being strong.
Let me give you a counterexample. My father is a veteran. He was shot, and his femur was shattered by a bullet, just bone chips from knee to hip. And he has had many complications over decades from that, and uh, including severe osteoarthritis of the knee. He goes into periods of remission for a year or two at a time. He's had, over the last 15 years, he's had about, 5 good long patches, relatively pain-free. And every time he flares up, he kind of panics and he thinks that's it. It's never going to get better. And I remind him, no, it comes and goes. And he's baffled by that. Why would it come and go? Like, why wouldn't it just get worse and worse and worse? And
Or why wouldn't it just get better and better and better?
or that, right? It's my general answer to that is that I think mostly pain rises and falls with the tide of metabolic changes that are just as complex as the movements of the oceans, that predictable in aggregate vaguely, but any given day, who knows what you're going to get out there. And so that's he's never been to the gym, but his pain too comes and goes.
Yeah.
And so I think it's conceivable, but I don't think there's much hope that we're going to line up um, uh, people who seem to get better with one identifiable biological factor or pattern.
Well, and you actually almost just actually contradicted with the last thing you just said, which is metabolic. Like that
Mhm.
would be one thing. It's just, it's one big thing. Like interoception essentially
Yeah,
is
sure.
one really big animal. And so it's like, is it these markers? Is it these proteins? Is it these molecules? Is it this behavior? Is it these hormones and flare up? It's almost too large of a component to count, but it is also one thing, which is essentially you as a human.
Yeah, it's a real mixed bag. It's real good news, bad news. I mean, basically, what we're getting to there is, does increased activity and exercise treat pain? And the general answer is no. There are lots of kinds of pain that just aren't gonna budge because you get more active. But like manual therapy itself, there do seem to be some benefits for some kinds of pain.
which
Mhm.
which kind of brings me back to something you spoke about earlier, which again, like you said, we're probably going to go into it a little bit more, which was the therapeutic alliance. Like if it is just one person, and
Mhm.
interoception is this internal experience with the metabolism and all these other things, but impacted by the external world. Like if
Mhm.
I see a bear, I have cortisol spike, I have adrenaline spikes, right? So my interoception is definitely affected by the exterior world. But if I also walk into a massage room and I see and I smell lavender and I hear music that makes me think of a relaxing massage, I may also have an opposite effect.
I was
So
just gonna say, I hate lavender.
exactly, right. For me, it's patchouli. For me, it's
Yeah.
patchouli. Like, no way, man. No, it doesn't do it at all.
Mhm.
Lavender, I don't mind, but I also lived in the south of France, and it makes me think of all those beautiful moments. So the question then would be, if the metabolic behavior, the neuroimmunology, the metabolism, the hormones. My wife is going through perimenopause. I know you recently had a post about that. Like all those internal factors that are playing into it. Should the theater of therapy not be trying to, instead of putting my money into spending
Mhm.
education, professional development on what I can do with my hands, the next modality,
Yep.
should I not then be spending it on every magician's trick in the book to make that
Mhm.
therapeutic alliance better? Make that
Mhm.
charisma the most powerful thing in the room. And if it means rock and roll or a yellow wall or a rainbow colored art to allow everybody to feel safe because it's a safe space, does it mean I
Yeah.
need windows and plants? Like, should I not be therefore spending my money on the therapeutic alliance because that can affect their interoception behavior?
Yes.
Fair enough. There you go. Care to elaborate? Any idea, any insights on that?
Yes. Yeah, I mean, I think that's the game. I think there, the term therapy theater, has a bit of a stigma, a bit of a stink on it, because it essentially comes out of critical analysis and skepticism. The implication being is that the theater or the therapy is just theater. But in the same way that there's nothing just about reducing anxiety and depression, there's also nothing just about an ethical theatrical, a non-deceptive theatrical experience. Now, maybe this is very tricky and weird. It gets, there's some fun ethical questions in here. We go to the literal theater to be entertained by a story that is a lie. It didn't really happen.
Even if it's a fiction.
Right. But we love stories and are deeply moved by them. I was watching Taskmaster New Zealand last night with my wife,
I
and
love it.
there's a contestant on season 5 who's an autistic lady with a PhD in theater studies. And my wife says, "A PhD in theater studies? What's that?" And I've got a background in theater.
Means she did a lot of plays.
I could only respond, with a nerdy, actually, hun. theater matters. Theater's, telling stories is a really important part of life. There's a lot there. There's a very rich history to storytelling, and it merges with healthcare. Stories are important in healthcare. We talk, again, kind of coming at it from the skeptical angle. There's often a dismissive tone regarding the quote unquote narrative of a therapy, the story that is told about what's going on and why. And the reason that it tends to be a negative, implication, the insinuation that a narrative is bad, is because a lot of the narratives are shitty. they're stupid narratives. So,
Because a lot of the narratives we're taught in school that the narratives are modalities, that the narrative is what I'm doing to your body. And that's not the narrative. The narrative is the experience being essentially co-written between two individuals.
Yeah.
And I think that's a hard thing to get students to understand.
And my point is that it's not that it does. The problem isn't with narrative itself; it's with specific narratives. In the same way that there's, you don't go to a bad movie and say, well, all movies suck because that one was bad, or because every movie I've seen for the last 6 months has been bad. Therefore, all of cinema must be terrible. There is such a thing as a good narrative. And there are good ways to create therapy theater and ethical ways to do it. And for me, the baseline is do whatever you like as long as you're honest, and as long as the person has a pleasant experience. If they have that's the bedrock. If there's nothing else, if there's no other benefit, they can still walk away and say, well, at least it was a nice hour. Begin with that bedrock and then see if you can build up to something, better, essentially leveraging the idea that you framed your question around, which is that maybe interoceptively things get interesting if the experience is rich enough or fine-tuned enough to the person, in the same way that you can watch a bad movie and have absolutely no emotional impact or benefit from it, but then the next movie you see changes your life. You're never quite the same again in a good way. You can be deeply and profoundly inspired by the right story. And that can probably happen in massage as well. And it's not because a fascial distortion was banged out of someone's back, but because they had a profound sensory experience that changed their impression of themselves. So I think therapy theater can be made into a virtue, and in fact should be the point.
So I just, a few things I want to go into. One is going to be ASMR later on, because we talked about, the feel good sensations in the body with interoception. And I've had several podcasts on ASMR, and I actually teach an ASMR massage. Because I happen to get ASMR responses. So I teach an entire 8-hour class about essentially getting the chills with no relief. And people who've taken it, it's one of my favorite versions of treatment. Like I would rather a back scratch from my wife or my kids than a massage any day of the week. If I'm in pain, just scratch my back. Everything is better. The whole world is better.
Great.
But going to the narrative of the stories, using some of the examples you use, which I understand are just, on the spot. So it's not a fully refined theory, but I know, let's say it's a horror film. I hate horror films. I love suspense. I love thrillers, comedies. Taskmaster is one of my favorite shows, all that kind of stuff. But my wife, she doesn't care for Taskmaster, and she doesn't like action films and stuff like that. So my question would be, if that's the case, and let's use fascial distortion method, since you had said fascial distortion. If I go get a massage and I get results and I like it, and let's say they do posture analysis, which people know that I think posture analysis is bullshit, whatever, that's fine. So if I go get a massage for the first time, or chiropractic or PT or any version of manual therapy. I'm going to use manual therapy from now on interchangeably with all those terms. And I get postural analysis, and I like that story.
Yep.
It's the type of story I like to hear. It's the John Wick. It's the story I like. And I walk away going, I enjoyed it.
Yep.
Does that mean it was bad?
Is that good theater?
Is that good theater?
Is telling people what they want to hear good theater?
It's a good to me. It's a good question because when it comes to research, no, not at all, not at all. But I'm also a clinician. Yeah. I'm not only interested in research. I'm interested in outcome.
Yep.
Now, if I give them the story of the posture and they walk out going, "Hey, I felt better," does the ends justify? Did they walk out going, "That's a story I relate to"? It's a philosophical, again, it's that ethical question of, does the ends justify the means? Even if you're upfront and honest, the whole idea of, open label or not. If I'd say to them, "Hey, by the way, I don't know if the research behind posture is really validated. Theories are that it doesn't do what it says it does, but we're going to go ahead and do a posture analysis on you anyways." I'm telling them, and I don't think it's real, and then I do it anyways. I tell them I don't think I can find a trigger point because I don't think I can, and yet I go ahead and I do something similar to trigger point therapy. I don't think myofascia can be stretched by mechanical forces, and yet I'm going to go ahead and do some version of that because it elicits a sensation in the brain. If the client or patient latches onto the story and they enjoy it, who am I as a therapist to say, my story is not good for you, or you don't like the story, or here's a different story, one that you may not like as much? Does the outcome not justify it?
Yeah. This is going to a very clear place ethically. It's unavoidable. We're going to end up asking whether or not placebo is ethical.
Oh, we can talk about that. I teach a class on placebos. I know how you feel about placebos. I know how I feel about placebos. And absolutely, I agree. Yeah. It's just, even if, let's say it's not even a placebo, let's say it has to do with anxiety and depression, which why they get better, sure, mechanism, possibly placebo. Outcome, not placebo. We see that it seems to help. So even if we're thinking placebo, open label or not, doesn't really matter. It's more, if the story is something that they enjoyed, who am I to say, "Oh, you don't like, you didn't like the Marvel movies, you like DC more," right? Who am I to say that?
I mean, that you can ask exactly the same question about much more specific medical interventions. That's why I say this is, inevitably going to end up at the placebo question, whether or not placebos are ethical, because you can frame that question that you just asked me exactly the same way about medicines. And the doctor says to the patient, "Well, we're going to give you what you want, whether it's right for you or not, because that's the story you want to hear." And I think we have pretty good reasons not to practice medicine that way. And therefore, I think we have pretty good reasons not to practice therapy theater that way. There's a gray zone. There's a big old gray zone between overtly, delivering a narrative that you essentially know is bullshit, but you're doing it because you think it will evoke a response in someone, and that response may be valuable, may be potent. So at one extreme, you've got that, where the clinician knows full well that they are basically lying.
Yeah.
And at the other extreme, you've got completely earnest, well-intentioned, I sincerely believe that this story makes sense, and may also work for you.
And it comes to a tricky point, because if a patient goes to see the therapist who says quite clearly, "I don't think this works," and the client doesn't get better, and then they go see another therapist, as most people do, and then someone says, "I do think it works," and they get better, and yet the research says it doesn't work, but they got better because they liked that story. Did the first therapist did the first therapist not do them a disservice by not giving them giving them the movie they wanted to see. Like you advertise Terminator and you show up and it's Rocky kind of thing, right? But there's no right or wrong answer to these questions. It's that philosophical thing of like, where are we as a practice? Especially since let's talk about higher medicines. Let's say it's medication or pharmaceuticals and things like that, or even a surgery or something like that. I think the answer in more modern medicine, it's the area of gray is smaller because the risk reward is so much higher in the risk category. If I cut you open and take this thing out of you, or I give you this medicine that's going to fuck with your metabolism or your interoception, outcomes could be quite severe.
Higher stakes, yeah.
If I massage you wrong, so you wasted your money. Okay, for some people, that is significant. Socioeconomic status is a thing. That's a big deal. But for most people, it's not the end of the world. I'm not saying it isn't the end of the world for some. I'm saying for most people, they go, oh, it didn't take kind of thing, right? Mm-hmm. So it's one of those things where the shade of gray is bigger because the risk reward is less intense in the manual therapy profession. So does that therefore make our storytelling, does it change our approach? Or is it more just, hey, if you have the rapport with the client, they're going to get better. And if they don't have the rapport with you, they're going to go see someone else. And even if their story, research shows us that story isn't real, but if they have the rapport with them, they're going to find improvement.
They're going to find satisfaction.
Oh, I like that.
It's an important distinction. Probably 80% of the people who say it worked for me, what they're really reporting is that they were satisfied, they were emotionally pleased with the experience, and their suffering was eased somewhat, but the problem wasn't actually solved, and or it regressed to the mean, and the therapy got the credit. So the majority of cases where people are satisfied because they were told what they wanted to hear, because the therapy theater suited their personality, suited their character, suited their ideological prejudices, whatever. Right. Remember that, some, if you've got a white nationalist on your table, the ideal therapy theater for them might involve saying terrible things about people of color. And that patient might be satisfied, and they might then go on to say, oh yeah, that racist therapist really helped me.
There's the quote in the title for the podcast right there.
But it doesn't necessarily mean that they were helped. And one of the earliest skeptical observations of my career is that I would guess that it was actually one of my first 2 or 3 cognitive dissonances. One of the very earliest signs that something was amiss, that there was something more going on that I didn't understand and I wanted to dig into. And that was how frequently people would say, oh yeah, my other guy does amazing work, amazing, miraculous, but I still really need help.
For me, it's one of the ones I hear all the time. Like, if you keep spending your money on the same thing and the treatment's the same and the results are the same, didn't Mark Twain say that's insanity? Like, what? Why are you? Oh yeah, I've been seeing them for 10 years and I love it, but I'm not getting better.
Yeah,
I've never understood.
What is it that they love? Well, they love a story that they're being told, but that story isn't actually quote unquote working for them in terms of medical outcomes. And this is a really strong pattern. And of course, with clinician listeners, is probably not a surprise to anybody. But if you're talking to a lay audience, people don't know this. They don't appreciate how frequently people say, intervention X was amazing. It worked for me. I'm still fucked up though.
Yeah.
It happens all the time.
It's one of the things I teach in my classes, which is you as a new therapist to a client or a patient, I think you have a reasonable amount of time, which is for me is about 3 months. If that client hasn't found the improvement that they're looking for, or maybe the satisfaction they're looking for,
right,
to have a better quality of life, then it's time for you to move on. It's time for that client to say, nope. But it's also your job as a therapist to say, it's not working. But there's so many therapists. I mean, they're financially constrained. They're not going to make rent. They need another client, right? So it becomes self-serving, but it also becomes one of those things where it's like, I really think 3 months is an important, and it happens to align with a lot of stuff around learning and things like that, and allostatic load and chronic pain is a 3-month window. So it happens to line up with a lot of that 90-day stuff. But I really think that a lot of therapists have a hard time accepting that if they haven't helped in 90 days, it's probably not it's not the right theater for them. They need a different film.
Yeah. Yeah. But how much therapy continues because the patient is enjoying the theater. And that, I saw that pretty regularly in my practice. And I was quite diligent about trying to fire people after 90 days if I wasn't satisfied with the results. But I had a lot of patients who would, basically say, I don't care. I want to keep going because I like the show. I like the experience, even if it's not, quote unquote, medically useful. And that speaks to the power of the experience. But it also speaks to the fact that although the experience is motivating, the theater is motivating and inspiring, it may not actually be powerful in terms of clinical effect. And that I keep thinking this as we go here, that ultimately what we're talking about is, okay, does good therapy theater, regardless of whether it's honest or dishonest bullshit or the opposite of bullshit,
or described or ethical, or that it's informed or whatever
it is, does the experience of being, emotionally influenced by the therapy theater, does that work? Is that effective? Does that help people with their pain? And that question, I think, remains unanswered with a number of discouraging signs and some obvious logical flaws, but it also isn't completely out of the running. And I think the really tricky thing about it is what I call the unicorn hypothesis, which is that it absolutely can work with just the right combination of factors and the right amount of skill. And I have nightmares. I have epistemological nightmares about how the hell would you ever prove that? What if it's real? What if really skillful theater for the right patient is very medically potent, but it only happens to 1 in 10,000 patients, which means it's happening thousands of times around the world every year. But the vast majority of patients and clinicians are never experiencing it or only experiencing it incredibly rarely.
The story I use frequently for that is, we've all heard of that story who had the client who has TMJ pain and they put in an insole and their TMJ pain goes away. We all have that story. Chances are it's because it's happened once. But let's say it's happened once. Let's say it's far more likely that it's not the ankle causing their TMJ pain. It's happened once. And so it's like that unicorn theory. It's just because it happened once doesn't mean every client who walks in with jaw pain has this experience. But that's where it gets tricky, because then in order to replicate that moment as a therapist, you kind of have to become a master of all trades. You have to become a true master of clinician. And that's a lifetime experience. And even after a lifetime experience, you can't get it. You can't be on. It's like Friday, 5 p.m. Like I don't work Fridays to start with. So let's say Thursday, 5 p.m. If I'm in my clinic, I'm not thinking of my clients. Even if I'm there in front of my client, I'm probably thinking like, God, I can't wait to be home with my kids, to have a drink, to relax, to cook a nice meal, because it's the end of the week. So how present are you truly? The same as every other job in the world. When it comes to the end of the work week, you're just a little less present. So then the unicorn is even less likely to be hit.
Get skittish.
Yeah. So, but I have, keep going. So, but I was just going to say, I feel like I could do 2 or 3 episodes, because I feel like the way I'm enjoying this conversation with you is similar. Like I had Ben Cormack on a couple of episodes ago, and him and I were talking, and it was similar. And with most of my most of my guests, it's the same thing. I like talking about the philosophy of therapy, because I think
I noticed. Yes.
I think that's really where we see mastery, though. I think that's really where we see people going, I've gone beyond, every client gets this exercise, every client gets this treatment, every client, the cookie cutter session goes away when you start thinking in terms of philosophy. So even though I think I could do several episodes of that with you, what I do want to respect the time that we have, and it's already been almost an hour. So what I do want to ask is, because I have a few other things I wanted to ask, and one was, if you came across, let's say you have a new student in front of you, new graduate comes to you. if you had to disperse two pieces of wisdom, one in the pro column and one in the con column, one saying, okay, when it comes to manual therapy, please stop saying X. And when it comes to manual therapy, please start saying X or Y. Mm-hmm. Do you think you'd have a chance to summarize what those might be? I'm not asking for a sentence. It's more
one in each column, one point in each column.
Yeah, because we could list all the research we want on how manual therapy is ineffective.
Yeah.
And we could get write-ins from people saying, look, I did this study in XYZ, and we'd be inundated with how it is effective in their research, because research is really designed around a very specific question. And if you do it right, you'll get the answer you want, even if that's not the individual in front of you in your office. It's just a generalized theory. So if we really break it down, what's something that as manual therapists we have done as a disservice to our clients that we should probably stop communicating to them? And what's something that really is of service that could help them walk away and go, okay, yes, I feel like I've done something ethical, good, and that they will actually get something from this experience that's valuable.
Yeah. I mean, I think I almost can't avoid the answers. They're so, particularly in the negative column, I think it's so obvious. I can't really imagine any other answer.
I'm going to go ahead and guess a word of structuralism. I might be wrong, but I'm going to guess that word.
Yeah, that would be my word, my umbrella term for that. But I'll dumb it down to posturology. Stop pathologizing subtle alleged problems with posture, and we can extend that just a little bit to broaden the umbrella to allegedly dysfunctional movement patterns. Stop pathologizing those. They're not the problem. There's so much evidence that they're not the problem. If it's subtle, it doesn't matter. So I wrote a post, I think it's about a year ago now. The gist of it was that the obsession with alignment and dysfunction of position and movement and alignment is not just still common. It's not just a powerful theme in manual therapy. It is completely and utterly dominant to this day, despite 30 years of research saying, guys, there could be a problem with this.
I don't know what I've done in my algorithm, but for some reason, whenever I'm on Instagram or YouTube, all I get are sleep pillows that are supposed to be good for you, how you sleep is wrong. And I'm like, I don't think this thing is paying attention to what I really do, because this is completely not the algorithm I thought I was imprinting onto the web.
Yeah. One of the main ways that I know that posturology is still hopelessly dominant is social media posts and the public response to them and the professional response to them. You get an almost unbelievable amount of enthusiasm and support for incredibly simplistic ideas in this category. Any attempt to push back, anything any attempt to criticize that way of thinking is hopelessly marginalized by comparison. It is not unusual for me to stumble across social media posts that have hundreds of thousands of likes and hundreds or thousands of enthusiastic and uncritical comments for the most brain-dead, simplistic, obsolete garbage that you can find in this business. So it's crazy how strong it still is. And
I like how you're avoiding the words red light therapy, cold therapy. I like how you're avoiding the words of all the things, but we all know what they are. We all know what they are. The bracelets, all those things. I love how you're being PC about it.
Oh, I just haven't gotten to it yet. But but the obsession with alignment is the top of the list. If there was one thing that I could tell a new graduate to please avoid, please consider not contributing to that paradigm, not extending it for another generation, that would be the number one. The positive alternative in the other column is much less obvious, much harder, and I risk simply repeating myself and saying that I think that the sensory experience is the thing. Try to give people a pleasant experience, if nothing else. It almost certainly has some powerful benefits. Like, for instance, I suspect that I don't know this, and I don't think there's any research that can answer the question for us, but I strongly suspect that the easing of anxiety and depression in massage therapy strongly correlates with pleasant massage experiences, not challenging ones,
So
not
there's
painful ones.
so there actually is a study that tries to correlate, and again, it's a leap in logic, but it tries to correlate the effects of C-tactile afferent pathways on the effects of increase in oxytocin and dopamine, which would counteract anxiety and depression. But it doesn't necessarily mean that that's the reason, but it is one of the theories. And it's, C-tactile afferent pathways, they're affected very much in a massage session. And so it's a small study, but it's one of those things that might lead down that pathway of possible mechanism. But again, my friend Justin Solis and Matt Gavi and Anna Rickenbaugh, they all say the same thing. Massage works. Like when you really boil it down, the mechanism, we probably don't know. And will we ever? There's a lot of variables. But does it work? Yeah, we see it works. And I'm kind of a fan of that. It's simplistic in nature.
Yeah. I mean, it is. Obviously, there's, tons of nuance. We can dissect that into many slices. I'm okay with, in a casual way, saying, yep, massage works, because I've had profound massage experiences. I've got my own little, got my own little bag of great anecdotes. But I'm also reluctant to say, yep, massage works in a formal sense.
Exactly. This was very much over drinks.
Yeah, over drinks. I'll put it that way. And it's not a matter of being honest in one situation and dishonest in the other. It's a matter of simplification versus nuance. Works for what? Are they satisfied versus treated? Did their suffering reduce or did their pain? And I'm very mindful of the fact that there are so many people, because I have chronic pain myself, and I'm now part of that community. I know so many people who suffer from terrible chronic pain that massage has never put a dent in, and some of it in a obvious way, like I'm trying to think of a condition that's just unambiguously never going to be successfully treated by massage, and I can't
CRPS.
think of one that.
CRPS.
That was the first one that came to mind, but I know
one of the highest up there.
It's let's go with that one. It's up there. But then there's also just lots and lots of examples of conditions that are at best very difficult to treat with massage, where the odds are not great. But yeah, maybe sometimes. So I'm very mindful of the fact that many chronic pain patients are not okay with saying, yeah, massage works. Like, yeah, well, it didn't work for me because I'm still pretty much living in hell, despite my massage therapy. But many of those people, and this is critical, right? This is circling back to my point, why I'm putting that point in the positive column. What should a new graduate focus on? I am one of those people, and I've heard from many of those people who say, yeah, it's not changing my pain. I'm not getting treated, but you can prime my massage for my cold, dead hands. I want my massage therapy anyway. Why? Because the reduction in suffering, the pleasant experience is precious. It's not treating their pain. That's a different thing. So what does massage, quote unquote, work for? If we clarify and say, well, it works for having really pleasant experiences. Oh, hell yeah, it does. It really can do that.
And sometimes those pleasant experiences will be significant enough that somebody might get short to medium term results from them. That's significant enough for them to go and have a change in lifestyle.
Yes.
For most people, it's just going to feel good for a couple hours, maybe a couple days, and then we move on. And yeah, to me, I love that. I mean, there's a reason my podcast is called The Sensory Approach to Manual Therapy. And that's what my business is called. It's literally like, when you said the sensory system, a little part of me kind of got all giddy inside because I was like, yeah, I've been talking about this for a long time kind of thing.
Hey, that's my brand.
Exactly. That's exactly the point, is that the sensory system determines what version of intervention you want. And, when we talked earlier about the theater of therapy, it's almost like I happen to be neurodivergent, and I have a lot of my clinic here in Sherbrooke. I get a lot of neurodivergent individuals, and they all want that's why I made that ASMR massage, because they don't want the elbow. They want the nail scratch. And some who like the nail scratch, they just want they don't want it. They want the elbow. And there's an entire theory that's beginning to gain a little bit of footing that I'm actually a big fan of this. I'm trying to follow it. It's so brand new, but it's essentially around phenotypes. Your phenotypes determine your skin tone, and your skin tone might actually be related to the version of touch you like. Low skin tone people like deep, firm pressure in the beginning. Once they feel safe, they like light touch. Sorry. Low tone people, opposite. They like light touch in the beginning, finished by deep touch. High tone individuals, not muscle tone, skin tone. In the beginning, they like deep touch to feel safe. And once they feel safe, they actually only just want light touch. And I happen to fall in the light or the high tone category. And it's true. Like, when I first go in for a massage, first touch, I want your elbow in me. But after I feel safe, just scratch me. Like, just go for the lightest possible feather touch. And I will love your, if you go deep for an hour, I'm like, okay, session's over. I want to leave. And it's just interesting because I think there's an early development in some versions of intervention where they're starting to go, okay, neurodivergent is significant enough that we should be paying attention to the nuance of how these individuals are, like, there's a reason we have sensory buckets and stuff like that. And so I think massage and manual therapy should be guided by similar guidelines. If their sensory system dictates that they don't like light touch, then don't do light touch. If their sensory system tells them they like light touch, do light touch. It's their system that tells you what to do. And that would be like what film they like, the theater kind of thing that they connect with.
Yeah. To use another metaphor instead of theater, imagine you've got your own personal cook, and their job once a week is to spend an hour cooking for you and trying to figure out what you love.
I love it.
What is your most satisfying meal? And I want manual therapists to know that I want them to make that the bedrock, the minimum, the thing you go for, that even if there's nothing else, at least you got that. But then on top of that, and this is important, I'm specifically saying this because I don't want to just be a stuck record saying your entire job is just to create pleasant experiences. I'm also assuming that by creating the most pleasant possible experience for your client, you are also potentially doing something more profound. If there's any potential for an effect on pain or other important medical outcomes, that's where it lives. If there's potential for it, that's where it lives. Now, you could come back at me and say, actually, certain medical outcomes might never be achievable without an unpleasant intervention. And yes, I'm not gonna categorically say that that's impossible, but I will categorically say it's unlikely.
Yeah, I can tell you right now, you can have really good ice cream without eating shitty ice cream. You don't have to have bad ice cream to eat good ice cream. It makes you appreciate it more, but it's still just good ice cream. Yeah.
And the problem with gambling on unpleasant sensory experiences in manual therapy containing some magic therapeutic ingredient is that your client gets nothing but a bad experience if you're wrong. The problem is that you're gambling, and it's not a very safe bet. And what I see from the clinicians who are the most gung-ho about gotta break some eggs to make an omelet treatments is that the ego and the ideology is intense generally. They're true believers, they're faith-based, basically they don't have what I would consider to be a good idea about what works and why. And so I think that most things in that category are low, they are bad gambles. Not necessarily impossible, but not a safe bet in general.
Yeah. And it's hard too, because our profession is really broken into, I mean, there was a post, Julia Leponorio put up a post yesterday where she had essentially typed into AI, and, she put all these really good, you know, delineations around the answer, but it was essentially, can you talk to us about what the problems in the current massage therapy profession are? And one of them was, it's essentially
There's
broken.
a bunch of this going around right now, by the way.
Yeah. Well,
A lot of people asking AI to summarize the problems with their professions seems to be a bit of a trend. Mm-hmm.
And one of the ones that she put up that I liked was that it's broken into essentially two fields. One, which is the spa profession, and one is more the medical or therapeutic, or however else you want to term it. And it becomes complicated because someone who wants to do, like, if you're looking for that sensory input, you can get it in both camps. But if you're doing the spa style environment, you're gearing the entire session specifically to patient satisfaction around the sensory system, through visual, through auditory, through sound, through everything about that experience is geared towards that. Now, it may not be the right one, but at least they're trying. At least that's the intent. And when you go down the therapeutic route, you're almost like, I don't, because I only do therapeutic care. And because my podcast is called The Sensory Approach to Radiotherapy, I primarily focus on sensory input in my clinic. Mm-hmm. But I feel like most is not that. Most they try to avoid the sensory impact, and they say, barring your sensory system, we're going to do X, Y, Z.
Yep.
And it almost seems asinine in nature. And it seems to be one of the complicated. It seems to be one of the complications we have in the profession, because the people pushing in our profession for more respect, more accreditation, more recognition is by far that therapeutic branch. And yet they seem to be the ones ignoring the fundamental value of what touch therapy could be.
Mm-hmm. Yeah.
And that's why it seems so weird to me.
Yeah, it's weird to me too. I mean, you're talking about a Venn diagram that in school, the circles were separate. Like, we are medical massage therapists learning how to treat people's flesh. And then there's those trivial and ridiculous spa therapists who are only about the sensory experience. And from day one, I'm like, just kind of get those circles overlapping a little bit more. And what you're saying, and what we've been saying this whole thing, is, but we just squish them together so that they're one thing. What absolutely drives me nuts about this dichotomy is that for different reasons, each camp, even when they're, completely isolated, they are screwing up the sensory experience in different ways. They're both doing it badly, one of them by generally ignoring it, and the other by sticking to all kinds of aesthetic cliches and stereotypes and cookie cutter. It's just low quality, right? Yeah. It's not the wrong idea. It's just really poorly implemented.
The law of averages.
And the law of averages, something I get, like, anybody who's over, 40 is starting to notice how more and more of their healthcare professionals basically seem like kids. And I had a spa massage a while ago, and the combination of their incompetence and their youth was just deadly for me emotionally. It's just like they just instantly started doing it wrong, and I'm like, and all I can think is, oh my God, they're just like the sheer tonnage of what this kid doesn't know about how to deliver a good sensory experience, a pleasurable massage experience. It's just there's no hope.
I know for a fact that we're very close in age. And I think it's wonderful how old you sound right now.
Also, get the fuck off my lawn. Yeah, so I would have objected to that experience as a younger client as well, but I find it amusing now to notice as an older patient. I go into that situation, and it's obvious to me that half the problem is just it's a kid. It's a kid. It's an inexperienced human who just doesn't know very much about how to create a pleasant experience for other humans. A great little story from my massage training, and a formative one. When I was in training, my very first night in the student clinic, This was at OVCMT, and some people will know who I'm talking about. The owner of the school was my first client in the student clinic, which was, intimidating, or would be intimidating for a lot of people. But I was already an older student. I entered the profession fairly late, wasn't too intimidated. He says to me, he walks in the room and says, "Hi, Paul, keep me warm or there's no point in me being here." Like, and the coldness and directness with which he requested warmth was quite instructive. It was a good lesson, because
It's almost heartwarming.
that's almost heartwarming how cold he was about. He
About warmth.
clearly, yes, he clearly had many experiences in the student clinic where the student didn't keep him warm. And that was essentially my first, the sort of first direct lesson about the sensory experience might matter. Right. And this was the guy who owned a school that was teaching massage therapists to be as medically and clinically minded as possible. Really, really trying to make
and
RMTs
the first thing he wants is to feel good.
is to feel good.
It doesn't matter if I have a school on yet. First thing he wants, I just want to feel good.
Don't really care what else you do. Just keep me warm, for God's sakes.
Yeah. See, I'm the
don't
opposite.
give me a bad sensory experience.
My therapist knows that, like, before I get on the table, she has, if she's had someone on the table before me and the table heater's been on, she's got to take that thing off because it's too warm for me. Like, I cannot stand a hot massage. I feel gross.
Oh yeah. Oh, if you feel like you're getting sweaty when someone is rubbing you,
or too oily of a session. Oh my God. And again, you said, like, some young therapists, like, there's no way out of being a young therapist. Time and experience is the only thing. Like, you just hands-on bodies eventually makes you better at understanding the sensory system. There's really no way to avoid that aside from asking them. And I think that's something I have a series of classes called Creating Empathetic Touch, and it's 16 hours in total. And one of the classes is 4 hours, and it's called Touch is Communication. Touch is the communication tool. And it's like, a lot of that is around, hey, does this feel good? Does this, your first couple sessions should be pretty question filled, not to the point of annoyance, but definitely to the point of what touch do you like? And knowing that on their feet, it might be a different touch than on their face. And accordingly. Yeah.
Yeah. You don't want your personal chef leaning over your shoulder and asking how each bite is. How was that bite? Was that good? How about that bite? It's getting to a consensus about what works for someone is an art in itself. There's the thing, but there's also figuring out the thing. They're both an art. It takes a lot of social skill, and this is why I've started to avoid young therapists, because they don't have that art, and I know that they're not gonna get there, or not without a lot of hand holding, and I don't really want to pay
so your next
$1.50 a minute for that.
Your next hate mails are going to be about ageism. You know that.
Yeah.
Well, awesome, Paul. I really had a great, I feel like I could do this once a month with you or something like that. I really enjoyed today. I really appreciate it. And before we go, do you want to talk a little bit about your stuff, so that if most of my listeners will know who you are, because I've mentioned your name in many of my other podcasts, but if they don't, do you want to talk a little bit about your stuff?
Yeah, sure. I make my living doing this stuff. So at some point, it makes sense. It's wise for me to switch my focus from the subject matter to actually promoting my stuff. I sell books, and I sell a membership program on paintscience.com. It's an amazing thing that people pay me to criticize them. That's my insane business plan.
I never thought of it that way, but that is absolutely what you do.
It is a bizarre business, and it's bizarre that I managed to keep this plate spinning. The idea is, the value proposition for the right customer is that I sell nerdy deep dives into this subject matter. If you're curious and enthusiastic about how all this stuff works, well, I got a busy mind and busy hands on the keyboard, and I write about it a lot, and I give away some of my best content to my members only. But the weird dark side of it is that I pretty routinely challenge the beliefs of my core audience. And it is not uncommon for me to lose money when I publish a post. So,
I love how lately you've been talking about how you're not completely opposed to trigger points, because for people who have read your trigger point posts, they would
yeah.
assume you are completely opposed to that.
Well,
And
let me clarify that, actually, because this is kind of a fascinating phenomenon, and it's exactly what I mean. And it's, and this would be, this is a selling point, right? This is why you should buy my stuff. It's a unique perspective. I am a fence sitter on trigger points, and my most prominent article on this topic consistently gets interpreted by both teams as their own. That whoever's reading it thinks that I'm championing their side. So anti-trigger point skeptics read what I have to say, and they're like, they are banging the table with enthusiasm. This is fantastic. And then people who like trigger point therapy read my stuff and are like, see, this is a sensible approach to the topic. It's fascinating to me how many times over the years, this by the way is rare. Most of what I write is polarizing, and I get hate mail about it from both sides. But for whatever reason, specifically that trigger point article, which by the way, if you want to Google it, it's called Trigger Point Doubts. That article specifically seems to get love mail from both sides. And
you need to write more of those just for your own self-soothing at night.
Funny you should say that. I try to, like, I'm trying to learn from the like, why does it work with this article? But the point is that that's thanks to nuance. That's thanks to a very, very detailed, nuanced, honest attempt to understand the subject without banging the drum for team skeptic or team quack. It's because I think it's basically because I put so much work into actually trying to understand and communicate the subject matter, and it works. Anyway, so I sell books and I sell memberships at painscience.com, and I do not have a ton of customers. 99% of massage therapists will probably never be members, but boy, the 1%, special club, awesome people.
And I will say, for those of you who do decide to read some of his stuff, bear with it. The first time you read an article, you'll walk away riling against him, or you'll rile against yourself. One of the two. You'll think you've been lying, or you think he's been lying. But read deeper, read more, and in the end, you'll come to a place of a really clear understanding of a larger picture of what we're trying to do, which is, Paul's been doing this for a long time. I've only been doing it 8 years. And there's a growing group, I should say, of clinicians and authors and influencers who are trying to help answer the question of not necessarily what's going on in the body, because that answer may be a little harder to answer, but more, is it working and is it worth it? And if it is worth it, how do we make it the most effective? And that's a tough question to answer, but it's a worthwhile question to ask. And I think it's one of the best things that I've seen about your stuff. So thank you so much for being here, Paul. I really appreciate your time and your honesty and the laughter. It was a very, very fun moment.
Thanks. Okay. Until next time then.
Yeah. Have a great day, Paul. Thanks.
Bye-bye.